really what our journey is in the South East. Still, Steve and others will obviously talk about it, but from April 2020 to March 2021, and you're going to be modelling the tool that's been developed. A number of you will have already be familiar. We've already also sent around some information, but this is really an update as to where we are. Just before we move into the NHS benchmarking element of the meeting today, just a really quick kind of mention, it is in the agenda. I'm sure you will all be aware of it. It has been sent round, but the Centre for Mental Health and NHS partners have developed an updated modelling tool, which was May 2021. We're not going to spend any time talking about it in the meeting, but just to flag that the data, the research has been reviewed, and there is some updated kind of forecasts on the basis of that modelling. But one of the big gaps has been children and young people, where there wasn't any really significant kind of research updates. Okay, but just going to hand over now to Steve and colleagues. Thank you very much for kind of leading the session today, and we'll hand over to you.
Steve, you're on mute.
Sorry, double click mania there. Okay, thanks, Michelle. So Steve Watkins, Director with NHS Benchmarking Network. I've got quite a few of my team here today, actually, who are here to help the session along. It can be found in the chat as well if we have any questions as we go. So we have Aidan, and Aidan has built the modelling tool that we'll be talking through in a second. Janet, Stephen, Ellie, Alex and Alison, I think, are all here as well, and they'll be really interested to hear your reaction to the data and also your thoughts on where you'd like to go next with this. And I mean, we're absolutely delighted to say that Olivia, Michelle, Katrina and team have confirmed that the Benchmarking Network will be working with the system for the next year. So we will be collecting data from trusts, we'll be producing regular reports, and we'll also be putting out several editions of the modelling tool as well. I think the current aspiration is that we'll make a version available each quarter, and that will obviously have the benefit of wrapping up the story for the region in terms of that COVID recovery process and transformation process. But we can also do stuff with the functionality of the modelling tool as well as the situation evolves. I think we're all aware we're not in a static situation at the moment. So the first time we met, the sort of vaccination programme was somewhere on the distant horizon. Obviously, things have played out really rapidly. But in some aspects, I think we all have a sense as well that the real impact of that sort of latent and demand that hasn't yet come through is still to be felt in mental health services. So I think the modelling tool will be really helpful as a resource during this process. So what we thought we would do today, I hope this is okay with everyone, is that we will share the region's story for the last year. So we've got that full year's data now, which tells us about what the evidence was in terms of that disruption, recovery and transformation process. We will, so we'll draw out the story. And of course, there's a story within the South East in terms of the experience of different parts of the system and different providers. And then there's also how the South East compares with the rest of the NHS. And the evidence is always fascinating because things do move in interesting directions. We'll give you a brief reminder of what the modelling tool looks like, but I think we'd be keen to leave at least 25 minutes, if that's okay with everyone, to get your thoughts on where you'd like to see this go. And you can make your comments as we go through the story, and we can use those as prompts via the chat when we get to actually demoing the tool. But, you know, all our developers are here today, all our analysts, and, you know, they'll be really interested in everyone's comments, everyone's reaction. Okay, so I think first up, it's really important to reference, I mean, we've really enjoyed working with the regional team in terms of facilitating the process, but also the reaction of providers over the last year has been incredible, really. So you can see that from August onwards, we've had a solid body of contributions from across the region, which is great. And these contributions have been turned around really quickly. So generally within a month of period end, we've managed to analyze all the data from providers and convert that into local reports. So that should give you a feel for the speed with which we should be able to get these new versions of the modelling tool available. So generally within a month of quarter end, we should be able to get new content out to everyone. So thanks to all the providers for providing their data throughout the year. We'll just now look at the region's story compared to the rest of the NHS. So this was the region's baseline position in terms of beds pre-COVID. So the UK average, this is just adult acute beds, the UK average was 20 beds per 100,000 population. And South East does have an interesting story, of course, because it has fewer beds as an overall system, so 15 beds per 100,000, so about 30% below the national average. And you can see there's a strong clustering of providers in the lower quartile there. So just for reference, I only do it once, but the colour coding from the centre is Isle of Wight in orange, Sussex in purple, Oxford in blue, Berkshire in red, Kent in yellow. We then have Solent in that light grey, we have Southern in that olive green, and then we have Surrey and Borders in pink, and we'll keep those colour codes going. So the region has a low bed base, and we'll look at other aspects of the region's infrastructure in a second. And of course, what happened in the early months of COVID, but we saw some beds taken out of the system, which was interesting. And the top line chart there shows us really how that story evolved across the UK. So about 5% fewer beds in April, and we've had a gradual recovery since then. And I think where we are at the moment is that in March 2021, we had about 2% fewer beds than the pre-COVID situation. So we're largely back to where we were before the pandemic started. And the story for the South East is that we still have 14 beds per 100,000 population. So it's a largely consistent story. Some providers have moved slightly within the pack there. And interesting, you'll see that Solent now have the fewest beds per capita of any provider in the UK NHS, which is interesting. Surrey and Borders also being in the bottom 5 there. That's the bed base. Another thing that did start to change actually as the pandemic emerged was length of stay. And this becomes a key modelling variable, which we'll look at later again. The blue area of this chart shows you 9 years historic time series data actually of average length of stay across the UK. This is still acute beds. And you can see that there's been a marginal edging up over the last 9 years or so. So we were just shy of 35 days in the pre-COVID situation. And what we have under COVID, and this is now monthly data shown in red, is that the situation got quite a bit more volatile between months. So we saw short stays in the first few months as patients were discharged. But then as more acute patients started to be readmitted, we saw length of stay starting to increase. And we also started to see an increased use of the Mental Health Act. And that applied in every single specialty, actually, where the Mental Health Act use did increase. And that's something you can see in the local reports which we've published. So that's the overall UK story. And this is the story across, this is the regional story picked out. So just for reference, the top chart there is average length of stay in the pre-COVID situation. So it becomes really interesting, doesn't it? Because although the region as a whole has fewer beds, about 30% more beds than average, you'll see that we start to get more variation across providers now. So from providers with quite long length of stay, such as Oxford, to again, providers with really short stays, such as Kent and Solent. And Solent become really interesting, of course, don't they? Because they've got a very small bed base. But the bottom chart there is the situation, the latest situation under COVID. So that's the year end, March 2021. So most providers actually have managed to slightly trim their length of stay. You can see how Solent have gone to now being the shortest length of stay in the NHS, and Oxford, where we know they've been pressured in terms of acuity because of the very low bed base in the county, have also managed to trim their length of stay. So it's interesting looking at the data, but we know that this is happening against a backdrop of slightly longer lengths of stay across the UK, which have started to emerge because of COVID. This is bed occupancy. So again, this is another byproduct of that overall system mechanics in terms of beds available, acuity of patients, use of the Mental Health Act, etc. And we're showing all 10 major mental health and learning disability specialties here. And each of those pastel colours represents a month in the life of COVID, if you like, from April in that very soft pastel pink through to March 2021 in that sort of darker teal blue. And you can see there's a consistency about the story there. Just for reference, the red dots are the historic steady state bed occupancies pre-COVID. And pretty much every specialty on the top row has a similar shape there of patients being discharged in March and April, and therefore we had lower bed occupancy than historic rates. But then that recovery through the summer and the autumn, and we get the second national lockdown coming in, we start to see a dip in bed occupancy. And as the most recent lockdown was released in March, we see that occupancy jumping up again. And it's a pretty consistent story for all bed types. Well, there's a couple of exceptions actually. If you look at forensic care down the bottom and rehab, because patients generally have very long lengths of stay, we didn't quite see that discharge phenomena playing out, but we are seeing generally a little bit more headroom on bed occupancy in forensic care than we've seen over the years. We must pick out CAMHS, because obviously even though CAMHS has had lower bed occupancy over the years than, say, adult acute services, CAMHS did start to overshoot those historic rates quite quickly. So there's certainly a new demand phenomena playing out in children's services. And we'll come to that again when we look at the model. And then also learning disability services on the far right, they dropped down quite early on actually, and they haven't yet recovered to those historic rates. So some interesting stories there between specialties. This is adult acute services in a little bit more detail now for the region's providers. You'll see that the top chart there is pre-COVID, and things were super tight pre-COVID. So it was 94% excluding leave across the region. And the region overall has got slightly more headroom now at the end of March. So it was 88% excluding leave at the end of March. And you can see that on the bottom chart there. Some systems were still really tight, and Sussex and Surrey come out, and Kent and Berkshire as well, all above average. But you can see on the right-hand side, we've got some interesting positions emerging there. So Solent, typically always low bed occupancy, but really interesting to see Oxford Health also starting to come within that lower quartile there. That's the beds. We look at IAPT now, just very briefly. We don't have the whole of the system's data for IAPT, and that's really because clearly there's a mixed economy operating in IAPT with both NHS statutory providers and also then VOs and other types of providers. At the moment, we only have the statutory providers data, but we can access the VO composite data at CCG level, which might be something we look to do in the next version of the modelling tool. So the top chart there, that's the overall volumes for the region. This isn't benchmarked, it's in absolute numbers. And the region as a whole has got very healthy demand for the common mental health problems supported through IAPT programs. But one of the sort of systemic changes we've seen because of COVID is that shift away from face-to-face care. So that's the bottom chart really. And that confirms that pretty much every provider has gone to a virtual or non-face-to-face model of care because of COVID. And you can see that nearly all providers in the Southeast, the statutory providers anyway, are now delivering 100% of care in a non-face-to-face manner. So 5 providers are at that 100% position. We've actually just got Sussex delivering some residual elements of face-to-face care, but overall the region's average is now that 99% of care is delivered non-face-to-face. And we'll look at the issue of digital in a second. So let's look at community, and of course this is where most people get their care. So this is the story of community referrals during COVID, and the top chart there tells on a monthly basis what happened to referrals, and clearly things were compromised because of the need to protect staff and patients, and primary care was really difficult to access, wasn't it? I think we remember those early months, and obviously IAPT was also difficult in the first few months. So what did this mean? Well, it meant that referrals coming through to CMHTs were incredibly low compared to historic averages for the first 3 or 4 months of the pandemic. So in April, we were about 40% down on historic referral rates, but credit to everyone. By July, we were really seeing incredibly strong recovery in those referral rates. However, through the late summer and the early autumn, as lockdowns reappeared on the horizon, you see that we didn't quite recover back to that historic position. So it was quite tantalizing for us as a team looking at when we would get to the recovery point. But the good news is that by March 2021, we did actually reach that historic average position. So that I think we were 5% above historic rates in March. So this now gives us a clue, I think, for future modelling about what we might now expect to see in terms of demand rates, which are higher than the historic rates. So we've gone from a recovery position to maybe questions about demand management and accommodating and coping with these new norms of above average demand. You can see the Southeast data there, and it's interesting on a provider specific level. The demand seemed to be incredibly high in the Kent and Medway system, much higher than historic rates actually. And then other parts of the system were also experiencing demand accelerating rates. So across the Southeast actually, demand rates were higher than historical averages once we got to March 2021. And that's even noting that community caseloads, for example, in the region would have been lower than the rest of the UK because of that background morbidity position for the region. So this is the overall story of the UK's mental health caseloads. So the blue areas are historic rates. So we did see gradual declines in community caseloads. There were some growth areas within that though. So clearly EIP, clearly crisis activity, clearly perinatal in particular. So the 5-year forward view and long-term plan areas were growing at pace. However, look at the red zone, which is the monthly data under COVID, and you can see the big drop we had in April there, where we were 10% plus down on historic rates. We haven't yet recovered the ground on caseloads, but we're getting close. But by the end of March 2021, we were 7% below historic rates across the UK, which meant about 50,000 fewer people on CMHT caseloads. So that's something to keep an eye on. And we've got the regions data here shown pre-COVID on the top chart, and then at the end of March on the bottom chart. So pre-COVID caseloads were about 18% below historic, below UK averages for the region, but that gap has narrowed actually under COVID. So remember I said we were about 7% lower on the previous slide across the UK in terms of caseload. The Southeast position is 3% lower. What that does tell us is that the access routes into community teams were kept alive, kept more vibrant in the Southeast than elsewhere in the UK, which meant that that bit of the system has not been as much as compromised as elsewhere. But look at the bottom chart. That's where CMHT caseloads now sit in the Southeast compared to the rest of the UK. Remember the bed chart that we started with, where all providers were in the bottom quartile, apart from Sussex and Isle of Wight. You can see quite clearly here that we've got 4 providers above average for caseloads on all CMHTs. So Solent, Sussex, Kent and Berkshire are above average in terms of community capacity. So it's a good news story for the system in that we've got more access to community care than we would expect to see. And this is the community contact rates. Remember, the key point here is that the providers are not in the lower quartile, which is where a large group of them are for beds. So it suggests that the balance of care actually within the system is working well in terms of prioritising community-based care. And actually, the number of community contacts delivered across the region in March 2021 was 7% higher than historic rates across the region. So the region has really responded and is now delivering more care in the community than it was in the pre-COVID situation. Of course, one of the big differences, though, is that the kind of care we're delivering has changed. So the top chart there shows us the first bar there, that's the pre-COVID position. 76% of all care would have been face-to-face before COVID, but everyone went off a cliff edge in March, April, as services had to go virtual. But look at the recovery. So 29% of care was face-to-face in April. We managed to get to 47% actually by April this year, so the most recent data position. So again, credit to everyone, and we're nearly at that point now where half of care is delivered face-to-face. And you can see down the bottom, the region actually offered more virtual care than the NHS average. So we've just got Kent with less virtual care there on the bottom chart, and providers like Berkshire and Surrey, Oxford, also Isle of Wight being really high actually in the top quartile nationally for non-face-to-face care. Of course, part of that story is about digital, isn't it? And actually the region is the best performing region in the country actually for digital care. The top chart there shows us what's happened across the UK, and we did struggle in terms of adult CMHT digital care offer. It was 3% in April last year, and it only increased to 7% by March. So it doubled over the course of the year, but still to relatively low volumes. But look at the position for the region there. We had 4 of the 6 top providers in the UK, digital care in adult CMHTs being within the region. And all but 2 providers in the region are actually in the top quartile there. So it was a really strong position by the South East providers. And actually, so the UK position was 7% of care was digital. In March, it was actually 13% across the South East. So in terms of the transformation aspirations with COVID, they've been more achieved in the South East than they have elsewhere. Quick look at CAMHS. So CAMHS, referrals, the blue areas are historic data. And there's a very crude but important story within that data, which is that CAMHS referrals doubled over the last 8 years. You can see that quite clearly in the 12-13 data there versus the 19-20. So we use this line, and it's an evidence-based position that CAMHS is the fastest growing specialty, major specialty in healthcare. It was before the pandemic, and actually what the pandemic has done is potentially exacerbated that situation. We've got the monthly data there in red, and you can see how CAMHS was incredibly volatile. So 53% reduction in referrals in April as primary care got more difficult to access and as schools closed. Quick recovery actually through the summer, second national lockdown, but we started to peak really at previously unknown levels. So in March 2021, referrals were 26% higher than they'd ever been in CAMHS. So that's the recovery, and it's some degree of pent-up demand coming through in the system. But the whole shape of that red area in the chart, this is an important one to note, was 11% smaller than the previous pre-pandemic year, 2019-20. So even though we had some real peaks in that data, we also had some troughs. The net impact was 11% lower referral rates across CAMHS in the COVID year. This is the region story here, and this is the March 2021 data. And in absolute headline terms here, the region was generating 13% more referrals to CAMHS in March than the UK average. Remember, the UK average was already 26% higher than the historic rates. So there is a massive upshifting in CAMHS demand, which is taking place at the moment across the NHS. But South East region is really at the forefront of that. And you'll notice some surprises there in the data where we have Oxford, we have Surrey, Solent, Berkshire, Sussex, all generating really healthy levels of demand in terms of referrals. Digital was a different story in CAMHS actually. So we went to 27% of all care being digital by the end of March. And you'll see across the South East that the providers generally did well. 30% of all care in March was through a digital platform across the South East. So that was the highlights for the region. So there was a lot in that story. I hope it was useful. And what we'd like to do now is just move into the second phase of the discussion, which is about what might happen next. Could I just ask the team actually before I do that, are there any clarification points on the questions in the chat that we need to pick up now before we move on?
Hi, Steve. I think we're pretty good. Gavin's just asked a couple of questions about contacts in terms of measure of spread of contacts. We do actually collect that, Gavin. We collect proportion of patients who received a contact during the month. So that's something that's in the reports and something that we can look at. And I think that's in the tool as well. And then your second point is around what constitutes a contact. I don't know if you wanted to pick that up, Gavin, if you wanted to say any more around that, and myself and Steve can come back to you.
Ellie, yeah, thanks. I mean, that's great to know that there's a measure of proportion of services open caseload that gets seen. Really good, really positive. Yeah, no, so this was just came out fairly early on in the first, or towards the end of the first lockdown within CAMHS. Particularly, we're having conversations about contacts. And we had some services in the region that were saying, look, our contacts are looking really good. They've remained pretty stable. Okay, they've switched to digital. But they're saying, but there's the devil's in the detail, and actually the contacts are maybe a 5-minute check-in to see if people are okay, rather than a full therapeutic session. So there's something around the nature of contacts that I think, as I say, where the devil's in the detail. I think there's also something around how many contacts are people needing by the point of discharge now compared to pre-COVID, because that has a really big impact on modelling around service capacity as well.
Yeah. Thanks for that, Gavin. Really good points. You're absolutely right. the devil is in the detail on this one, and I think it's implicit within the amount of telephone-based care at the moment that we have a different type of contact which is taking place. One of the things we're actually collecting this year in our CAMHS annual benchmarking is average length of time of contacts. That's one to keep an eye out for as this evolves. But again, let's maybe take that to the modelling chat, because I think being able to infer how many contacts are delivered through each medium will be a really interesting bit of the analysis going forward. So how many face-to-face, how many telephone, and how many digital? That might be something that we can get some added value out of, and watch those proportions shift as well over time. Okay, thanks for that, Gavin. Thanks, Ellie, as well. So the next phase then, in terms of what happens next, obviously, there is a lot of published literature which continues to be produced in this area. And just to give everyone assurance that we're keeping an eye on this and we're monitoring all the publications. And we have a synopsis of all those publications in the literature review, which you can access through a hyperlink in the modelling tool, which we'll get to in a second, right? So there's a lot of published stuff on the adults area. Probably most stuff actually is around the psychological therapies, common mental health problems. So that's where most people's attention seems to be going at the moment. And I think, as Katrina said at the start, the CYP zone is a bit thin at the moment, and we've just come across 3 published papers there. But let's keep an eye on that, and we'll continue to gather that data and use the modelling application as a platform where you can hyperlink and download that material. So we'll go to the modelling tool demo. I just want to remind you now how it works and what it looks like. So these are just flash slides. So it's a desktop application that Michelle issued a previous version of a few weeks ago. We'll have some quite strong version control on this, so you'll know where you are with the data. There's a ribbon control menu where you can access the user guide, bit of background data, and you can actually access the different domains within that. So adults care, children's care. We're going to have a new button for IAPT actually, which we'll show you in a second, also learning disabilities. Within that, you can look at inpatient data, community data, and also modelling around each aspect of that data. You can look at the literature review I've just mentioned, and you've got a full user guide. And the user guide looks something like that. We might just start the demo in a second by just warming up on that user guide. Key point is, and this is hopefully value added for the system, is that we will bring all of the UK's data to the modelling tool every quarter as we update it. So you'll be able to view a UK-wide position as well as the version for individual providers within the South East. And you can choose from the menu either a UK-wide data view or a South East data view there. And the interactive maps will update each time you do that. And then there's a load of benchmarks you can see on the rest of that menu there. So you can look at raw data, you can benchmark for 100,000 registered POP, 100,000 weighted POP. You can also look at certain other benchmarks such as conversion rates, etc. within the tool. So that's the core data. So we would hope that the tool becomes a reference point for you to find data for your local system and to track it over time as well. Of course, what we're going to probably spend most time on now is this, the modelling and scenario sort of envisioning aspects of the tool. And on the adult side here, you can split your modelling aspirations between adults and older adults. That's just one of the current illustrations. And we might find that we put more buttons on this page as increasing numbers of different types of preset models start to emerge within the tool. So we'll quickly look at one for adult acute inpatient care in terms of beds, admissions, discharges, bed occupancy, etc., which was a concern in the first few months of the pandemic. So just an example here about the issue of recovery in inpatient services. So we have the top chart there is all South East trusts, and we can see that admission rates there fell in the first few months of the pandemic. And what the dotted line there shows is a recovery journey to try to get back to historic rates. So we've got some sliders there where you can model recovery trajectories. So do you want to go back to 100% of normal activity, maybe 90%, or maybe 110%, or even higher? And then there's a time aspiration there. Do we want to come back quickly within 3 months? Do you want to take maybe slightly longer to do that? So these are areas that you can use to explore both local data and region-wide data in the modelling tool. And you can also, that's about recovery, but there's another big aspect, isn't there, about this discourse, which is about the activity that we missed over time as well. So fewer people were admitted. Are we expecting to recover any of that activity now, or are we moving on to another plane of activity almost? This might be more of an issue, in truth, in community-based activity than in inpatient care, but it does give you an ability to model the activity that was not provided during the pandemic as well. There's also some scenario modelling around particular dimensions within this. So, for example, if you wanted to look at inpatient recovery in terms of stories about additional admissions we would expect to see, or changes in bed occupancy, and how you might play around with those variables in terms of thinking about what beds we need in future. And we know that quite a few providers did have to go down the route of contracting in bulk with private sector providers to make sure they had enough bed stock to meet that sort of surge in demand that came post-lockdown. So the tools will allow you to do that. And of course, you can do this on the community side as well. So again, we've got the issue of future trajectories there and getting back to normal business. But then down the bottom, we've also got the story of activity that was not provided and stuff that was missed that we might want to go back and recover on to make sure that people's condition doesn't worsen because of a lack of access to care. So hopefully there's some useful aspects there, and I hope that was useful in terms of a quick reminder. What I'm going to do now is load the modelling tool, and we can maybe have a bit of a play with that. But Aidan, Ellie, Janet, others, any questions at this point or any queries from people?
No, I think we're happy to move on with the modelling tool.
Thanks, Ellie. Okay, so we've got 25 minutes left basically, so we're approximately on time, and we can target this discussion in any which way people feel. So what I'm going to, so we could explore different scenarios perhaps. What I'm going to do now is I'm going to share the latest version of the modelling tool. Hopefully, there's always a risk on these things, on these interactive things, that things don't quite go to plan in terms of the connectivity. But let's see how we go here, eh? Okay. Is that shared okay with everyone?
Yeah, we can see that.
Fantastic. Okay, thank you. Okay, so Aidan, I'm not sure whether you want to say anything about how you constructed the tool here in terms of maybe the help menus and the user guide, etc., and the ribbon at the top for navigation.
I can give a brief talk over. I mean, the aim is really to sort of present it to people in as user-friendly as way as possible. So the tool is built in Excel and Visual Basic, but we've sort of stripped back the ribbon and provided a sort of bespoke ribbon to sort of only provide access to it. So it's a much more as if it was a standalone piece of software rather than an Excel toolkit. The ribbon is sort of split between adults, children, learning disabilities, and IAPT, and then each of those ribbons then has a set of buttons enabling people to access the individual content. It starts off obviously with just a sort of about the tool guide, then it goes on to the user guide, which basically hopefully gives people the impression, a relatively clear indication of everything that's contained within the toolkit and instructions for how to follow it. So Steve, can you just go back briefly onto the about the tool guide, just to kind of cover something which Steve raised earlier. So the literature review which we produced is available for a link from the green button on the right. So if Steve just clicks on that, then it will basically ask whether it wants to upload a tool, and then the literature review will download. It'll probably turn up on a separate one of Steve's screens now.
Yeah. It's there, Aidan, yeah.
But effectively what that means is that obviously the literature review again is a bit of a live document. Things change, and we produce updates for that, so we can then link it to the updated version of the literature review, so it downloads it from the internet, and we can refresh that literature review as things change.
Thanks, Aidan, that's fantastic. Okay, so what we'll do now is we'll just quickly put it through its paces. So I'm going to click on the inpatient data area there. So remember, This is the zone that's pre-populated with the UK's wide data, and we'll update this for you on a monthly basis. So the next edition of the tool that we'll produce after today's seminar will have data through to the end of March. We'll make this nice and neat in terms of quarterly data. And we can choose any number of metrics. So, for example, you could explore the bed base of the region. I know that you've got a series of denominators you can explore from the raw data there, and it will change the amount. Remember, we only had Sussex really that was coming close to the NHS average range there. And you can remember, Sussex are a big trust. You can benchmark that per 100,000 registered population, which will contextualise, and therefore the Isle of Wight pop into that zone because the Isle of Wight had bed numbers, you know, recognising the diseconomies of delivering, diseconomies of scale of delivering on the Isle of Wight. The Isle of Wight's bed numbers are round about average as well. You can see we've got low bed numbers elsewhere in the region coming out, slightly lighter colours there. And you can choose any number of denominators there. So you've got a range of adult acute denominators, admissions, discharges. Mental Health Act admissions are interesting here. So again, if you select a denominator here as a percentage of all admissions, this will give you a view on clinical practice across the NHS. So again, it looks like we might be missing a denominator there, perhaps for Sussex and Isle of Wight. But you can see already in terms of acuity that Oxford Health are coming out as having high use of the Mental Health Act, perhaps Berkshire, maybe Kent as well within that group. As well as having UK data, obviously you can just chunk it to the southeast position to see the regional position within the data as well. We've not just got adult acute on this drop down here, but you can look at old age mental health data, you can look at PQ, you can look at eating disorders, you can look at perinatal, you can look at forensic care, you can look at rehab. So lots of different bed types. The one thing to note though is that because a lot of these bed types are what we might define as regional specialties, you can't always benchmark them per 100,000 population because some of them could have a national population catchment footprint, such as in forensic care, for example. So you will be able to access source absolute level data, but perhaps the areas that are best suited to benchmarking will be the adult acute side and also the old age side. Before going to the modelling, I just want to show you maybe some of the community data. So again, we've got a lot of content here for you, both UK and regional, and you can look at any number of metrics. So referrals is obviously an area with a lot of interest. You can choose the raw data, and you know, so you've got Kent popping up there with that specific story that seems to be coming through the pandemic. You've got that now benchmarked 100,000 registered populations. So Kent again looking like an area of incredibly high demand across the country. You know, so from referrals, you've got the acceptance rate, patients on caseload. You've got the issue there of the face-to-face and non-face-to-face contact, and you can explore that data with a deep dive into crisis care as well. I'll maybe just look at children now before we look at some of the modelling aspirations. So everything's colour-coded, so you know that all the adult charts in here are now blue. When we go into children and look at the community data, children's is colour-coded, or apricot, let's call that apricot, hey? And I think IAPT is coded bright yellow. So we do move through this data. Let's look at referrals received, which is the big hot topic, isn't it, in CAMHS? And we'll look at the raw data here. And you can see again, we've got those hot spots within the region. So the Thames Valley area there, Surrey and Borders again. We haven't got the data for Kent actually at the moment, and this is worth talking about because with NELFT being the provider for both Kent and Essex, and we will look to access that data as the tool evolves. And NELFT are happy to share that data, which there's just a slight issue at the moment about splitting the data out from the NELFT perspective. And then when we benchmark that per 100,000 population, you'll see that the story of high demand really starts to come clear for the region. So you've got the Thames Valley, Surrey, and also the Solent area coming through with really high referral rates there. So lots of other metrics within that zone there, from caseloads levels through the type of care. So you've got digital as well coming through as an option, with the region figuring really strongly there within that national range. Okay, so I hope that was useful as a reminder. And maybe before I open this up for discussion, we'll just look at the inpatient modelling side now. So if we look at the inpatient trajectories here, we can choose any trust here. So Surrey have just come up as the default there, but you can look at any provider, you can look at the total South East region. But for Surrey, we can see that Surrey's inpatient admissions were impacted quite strongly there. So the recovery story for Surrey is quite steep actually in terms of access, in terms of providing inpatient care at previous levels, although we do know that I think Surrey, one of those providers which did access independent sector beds as part of that solution. So you can change the recovery aspirations. You can go to 110% of normal level, which obviously shifts the dotted line above the historic rate. You can keep on pushing that with the sliders there to take that line even higher. And you can flatten it by taking maybe a more reasonable approach in terms of the time over which that journey will be recovered. And you can look at you can look at the region as a whole. You can see that the region as a whole did suffer lower admission rates, as did the rest of the NHS, remember. But again there you've got those preset recovery aspirations. The table also changes as well to give you absolute volumes in terms of the number of units of activity that you're looking to recover by. And then within the surge modelling side of this, you can model specific variables such as number of beds needed as you play around with how many additional admissions you might expect to see. So if we look at the Isle of Wight with relatively low admission rates, as you start to increase those expected admissions, so the bed occupancy, the number of beds needed will also change. So more beds needed in the Isle of Wight as you start to anticipate additional admissions needed. Of course, one of the things you can use to manage that is that you can increase your planned bed occupancy as part of your strategy, actually. So if you increase the bed occupancy rate here, once that thing stops clicking through, you will find that the number of beds needed starts to fall in time as well. So that gives you a feel for the type of things you can do with the tool. I'll maybe drop the screen now. Well, I'll tell you what, I'll keep the screen there so that we can maybe look at any particular aspects people have. But this is a bit of an open discussion now. Do people have thoughts about the type of stuff you'd like to see in the tool going forward? Maybe if I'll just stop there, and if anyone wants to come in with any questions, either from the raise hand function or through any comments in the chat, are there any key information needs that people would like to see met in future editions of this tool?
Hi, Steve. I think we have a question from Bobby. Hi there, Bobby.
Hi, Bobby.
Hello. Hi, Steve and team. And hi, Katrina.
Oh, Bobby, I'm so glad it's you, Bobby. I was wondering.
I've been lurking. So I bet you can guess what I'm going to ask here. Obviously, the only way the more beds isn't the only way to model the increase in demand. And I think the thing that people have asked us, and we have kind of failed to be able to do, is to sort of have it cut differently. So, if this much more demand was coming, how much would we either need to reduce length of stay or increase capacity in community teams or have more beds? I don't know how possible that is, and it's way beyond my kind of mathematical analytical brain. But
no, Bobby, you're absolutely right. We've gone straight to quite a silo-based way of doing this, haven't we? But you're absolutely spot on. We've got inpatient beds almost as a separate modelling zone here, and then community as another modelling zone. And we have this infographic called the Bobby infographic, which compares bed numbers to the number of people on community caseloads. And there is a ratio whereby an adult acute bed has about the same unit cost over the course of a year, supporting about 42 people on a generic CMHT caseload. So maybe there's something here about letting people play around with that as a metric, about some of the opportunity costs of looking at some of the choices you have for your future provision.
Yeah, and the other thing, and I know Ian Davidson, I think he gets this from you maybe, or from NHSB, other sort of metrics on length of stay. So for example, if can we have it where if we reduced our 0 to 3 day admissions by X%, it would free up this many beds, or if we reduced our 60+ day length of stay by Y%, it would free up this many bed days. And I think that sort of, because obviously I think people feel a bit of despair when they think we need more beds and we can't commission more beds, or it's not easy to keep doing that. But it probably does feel achievable to reduce the really long length of stay or the really short ones. And my understanding is that it's actually a hell of a lot of bed days that would free up, even with small percentage reductions in some of those. So that could be useful for this as well.
Yeah, but again, really good question, Bobby. There's a parallel piece of work at the moment taking place with the South East CEO group, which is looking at exactly that issue about the long stay patients. So nationally, it's 8% of admissions are patients who stay 90 days or longer, and they account for 43% of England's bed stock. So optimizing that group becomes so important in terms of flow. I think probably what we'll do there is we'll wait for the findings of that work, but we actually only update that data once a year in terms of the data burden on providers. But it might be a high value area that has a place in this tool as well, in terms of playing around with reducing those percentages and what it might do for availability of beds. Yeah, really good question, Bob.
Thank you.
And thanks for joining as well.
Yeah, I mean, just obviously great work as always as well. I had to say that as well. So thanks.
Thanks, Bobby. Any other questions, Katrina?
Sorry, I was on mute then. No, there's no other hands up that I can see. I'm just having a quick look at the chat. Yeah, can't see. Oh, it's something here from Steve Farrow in relation to System 1. I don't know if you can see that, Steve, from just 1446.
Okay. Can you read it out, Katrina? Sorry, I can't see that.
Yeah, could I possibly inquire what other providers in the area use System 1 as their clinical for AMH and CAMHS, please? I mean, maybe that's more for chat rather than response from you, Steve, just reading it.
Yeah.
Brilliant. So any responses on the chat would be really, really helpful. I can't see anything else, but I may have missed it. Emily, your hand's up.
Hi, thank you very much. A commissioning programme manager for the South East region, and this is really, really helpful, Steve. Thanks ever so much, and it'd be great to have a copy of the slides. I've got the report in the meeting, but I noticed some of the graphs aren't in the report that were in the presentation, and they're really helpful. The other issue as well is when we've been doing local modelling in the region, the provider collaboratives in the South East region, we found the dynamics of the pathway and the clinical models really essential in kind of understanding and unravelling the model. So for an example, is the highest area of pressure is eating disorders, but also unravelling that and revealing that there are a large proportion with disordered eating rather than eating disorders, and that the approved model would be the GAU pathway with NG feeding potentially. They're not going to be specifically eating disorders beds or specialist eating disorder units. They're going to be in GAU units with potentially shorter lengths of stay in GAU pathways. So that's it's understanding the dynamics of the pathways, what I'm trying to get at, and integrating that with the modelling.
Yeah, again, it's a really good question, Emily. I mean, it's probably in the very difficult zone, this, in terms of delivering, because it's incredibly dynamic, this situation around disordered eating at the moment. It's interesting, actually. We're doing a point prevalence study at the moment with both NHS Wales and also with the Southwest region, because I think the first thing is to find out the scale of the problem, and then in terms of solutions, there's a combination of issues, isn't there, about rapid access to community-based crisis services. But at the moment, demand is overspilling into general peds in several areas. And I'm not quite sure whether we can confidently capture all of that stuff. But you have raised a really important question for this model, actually, which is that the data is quite macro in its nature, because we aren't looking at nuances within team. But maybe eating disorders within CYP could be an area where we decide to go a little bit more granular on the data, because everyone's struggling with this at the moment. That's something I think in consultation with the sort of wider provider group we work with, we might be able to get on the agenda over the course of the next year. Yeah, thanks.
Thank you.
Thank you, Emily. Thank you, Steve. Really, really helpful question and also response from you, Steve. David Cullum, your hand was up, but I just wanted to check that your question had been kind of responded through via chat.
I thought I'd take it offline actually, so I'm just scripting that up.
Okay, brilliant. Thank you. So unless I've missed anything, I don't think there's anything else, but we did want to ask a question.
Sorry, Katrina, there is one from Karen Stevens. So is there a link to resourcing for any of this, or is this planned for the future? You might just need to clarify, Karen, exactly your question.
Yeah, I'm thinking that obviously with the swings and roundabouts, the increases, decreases, etc., whether there's any correlation with the staffing or resourcing that might need to go alongside that.
Yeah, it's a good question, Karen. And again, it's not something that's in the tool at the moment, but it's not an impossible thing to do. I mean, we would need more granularity on the data. I mean, we know, for example, what an average caseload is at the moment across the region and nationally. I don't think there's been work done yet, though, in mental health services, which says what an optimal or desirable caseload is for the future. So I think there's always something about the sort of building blocks of capacity and the sort of veracity or the firmness of them. Yeah. So would you plan on the basis of what you've done in the past? If that was okay with everyone, you could probably build a forward-looking model around that. And of course, unfortunately, the workforce and the resourcing tend to be quite fixed in many ways. It's often quite difficult to flex that. And of course, the thing that happens if you can't flex the workforce and the resourcing is that you get waiting lists emerging in the system as well.
Brilliant. Thank you. Thank you. Just last question from you, Steve, just aware of time. Thanks, Steve.
Yeah, just a very, very quick one. It's based on my question about other users using System 1. There are challenges within the system of us capturing whether that's being done via video or not. So I'd just be interested to see how we can get that captured somewhere so that we can benchmark ourselves against other people using the same systems where we may have known system issues and potentially work together to fix those and come up with consistent ways of getting the data through to you.
Thanks, Steve. We have a mental health reference group where we do talk about sort of vendor specific situations. I don't think you're on the reference group, Steve, but you'd be very welcome to join at any point in future. And we do regularly take observations actually about some of these hot topics around MHSDS and vendor systems and how we properly record data. And we try to help by sharing ideas on fixes, basically. So you would be welcome to take part in that network if it would be of interest.
Yes, please. If someone could send me the details, that'd be brilliant.
Fantastic. I mean, drop us an email to the team, or if we've got your details, we can send details over you.
Well done. Thank you very much.
Brilliant. Thank you, Steve. And well, thank you both Steves very much for that. And Steve and colleagues from NHS Benchmarking, just huge thanks for the brilliant work that you're doing. Really great to get an update from our previous session, and also just fantastic to be working with you for the next year as well. So really, really good. So thank you. We just wanted to just spend a couple of minutes just kind of tying up where we are. I mean, we are really keen to hear from everybody kind of who's in this meeting today, because we are going to be having quarterly kind of sessions, which is the updates to the tool and the new data to share with you. So if you could add in chat whether you would like this kind of way of doing it, quite a quick kind of meeting running through things, or whether you would like something which is a bit more on kind of themes or issues for discussion and exploration. So just let us know in chat. That would be really helpful so that we can plan the future sessions that kind of meet your needs and reflect obviously how busy we all are with meetings as well. I'm going to hand over to Michelle, who's just going to be talking through the next steps in terms of meeting dates and things. But again, thank you, everybody. Really good to see you. Just the final thing is we will send round with the meeting dates, the tool and all the information, so you've got that to use locally. Thank you. And just over to you, Michelle. Are you with us, Michelle? Michelle did say she was having computer issues, so we may have lost Michelle. In which case, certainly I can update on the next meeting. So we've got the 7th of September, 7th of December, and the 8th of March next year. So we'll send round and pick up the kind of comments about the type of meeting and the length of meeting that you would all like. So again, just a really big thank you from me. Steve, any final kind of goodbyes or comments from you?
Just to thank you everyone for attending today. We really appreciate it's a system-wide project, this, so it's it's at every layer of the system, isn't it? We will, as Katrina said, the slides will be made available so you can see that regional story for the year, and the team will be working on an updated version, so version 1.1 or version 2 of the model, which we hope to make available to you round about the end of June. So keep an eye out for that, and then you'll be able to use that. And when we meet in September, we'll have Q1 story pretty well established, and and we'll have another version of the tool available for everyone to use then as well.
Brilliant. Thank you very much, Steve. And of course, thank you for the team doing all the hard work behind the scenes. So we'll be in touch with the actions, with the next dates, with all the information, and also we'll send around the email address if there's any queries or contacts from NHS Benchmarking. Michelle, you're back, but I think we've covered
very much.
No, that's fine. I think we've covered the next dates for the meeting and everything.
Okay, thank you. Hopefully it's mess up the recording too much. My PC just decided to have a burnout in the middle of a meeting.
All right. Well, thank you, everybody, and take care, and we'll be in touch. Cheers.
Thank you.
Bye-bye.
Bye. Bye.